Hi there. Welcome to the While You Wait podcast, where it's all about helping women just like you learn about the bladder while you're waiting for your appointment with that specialist. Each week, I'll combine science, medicine, and common sense so you can learn, become empowered, and get started on your journey to dryness. I'm your host, Dr. Sarah Boyles, a board-certified urogynecologist. Let's get started. Hi there. I'm here today with Anand Jain, who is the medical director of the East Pavilion Surgery Center here in Portland, Oregon. That's a surgery center that I work at a lot, so we collaborate frequently on patient cases. And we're going to talk today about surgery at the surgery center and what that is like. So good morning. How are you today?
Good morning. Yeah, I'm good. Thank you.
That is the shortest answer I think I've ever heard you give.
It's probably the shortest answer you're going to get today.
Oh, good. So, we're doing a lot more surgeries in surgery centers these days. One of the things that I always say to my patients is that the hospital's just busy doing so many other things. And surgery centers are just focused on surgery. And so they're a very efficient place to have surgery. But a lot of people have questions. So what would you say the difference is between surgery in a surgery center and in the main hospital operating room?
That's a really good question. I think the biggest difference that patients would experience would be obviously on the patient experience end. Like you said, surgery centers are focused entirely on doing outpatient surgery. We can talk a little bit more later about what that means. Whereas hospitals are in the business of providing medical care for a whole variety of other issues, whether it's inpatient care, outpatient services, imaging, labs, things like that. So patients would often find that surgery centers seem to be more focused on the patient's experience in terms of how they get through the surgery in the pre-op, the OR, and the post-op experience. By the very nature of the surgeries that are done at a surgery center, oftentimes these surgeries are shorter. So you may see that the surgery center seems busier than the hospital because it is oftentimes. And patients, by definition, are ambulatory. So they're able to walk in and expected to walk out at the end of their surgical visit.
What about safety? Because I think that's the big question, right? Where a lot of people wonder, if this is just kind of a surgery factory, you're running people in and running people out pretty quickly. How do we know that it's a safe place to do surgery?
Sure. So again, a very good question. Safety is always, or should always be at the top of the priority list for both hospitals and surgery centers. Both hospitals and surgery centers have to go through accreditation process through a national governing agency. And a surgery center and a hospital wouldn't necessarily be able to operate, pun intended, without that accreditation. So that's sort of the basic ground layer of safety. The second layer for safety would be ensuring that the patients are able to have their surgery and do well. And if you want to say that the gold standard is to do as well as they would in the hospital, then the biggest or the first factor that you'd want to consider is the surgery rightfully considered an outpatient surgery? So you have to take a look at what are the resources available or not available at the surgery center. And specifically with the surgery center where we work at the East Pavilion Surgery Center, one of the big limitations could be considered the inability to give blood products. So if we expect a surgery to require things like a blood transfusion or to consider the patient to be at high risk for needing a blood transfusion, we right off the bat would not schedule that surgery at our surgery center. In order to achieve that level of safety, I work with the surgeons in their offices to help develop screening protocols for both the patients and the types of surgeries to ensure that the right surgery and the right patient is being scheduled for the surgery center.
So let's talk about that a little bit. So
Sure.
What kind of rules, I know what the rules are, but let's just talk about the rules that we have for patient selection, right? I think that's an important one to know whether in general you fit the categories. The big one that I always think about is weight. Right. So heavier patients have more risks. And so there are BMI cutoffs and there are weight cutoffs for the surgery center. Right. So weight is kind of the big one. What other ones do we have?
Yeah, so I want to refer to the great cinematic masterpiece of Pirates of the Caribbean. They're not really rules as much as there are guidelines. And that's what we have.
That's where we're going. Okay.
Just the first Pirates. The others were complete garbage. But honestly, like what we have are guidelines. And the reason for that is it's very difficult to establish a hard and fast set of rules that could universally be applied to all circumstances, especially at a surgery center like the East Pavilion, where we do a wide range of surgeries. We do adult and pediatric surgeries. We do very quick 5-minute procedures and 3 to 4 hour procedures. It's difficult to say that this is an absolute cutoff. For us, the other complicating factor is that we have very skilled surgeons and very skilled anesthesiologists who have worked together for at least 10 years.
Is that a compliment? Is that
for
what
me? Yes, it was a self compliment.
Oh, I thought you were complimenting me. Okay. All right.
With you, it's just the truth. And so we know what our skill sets are. We know what is the emergency equipment or the special equipment, if we were to need it, that we have available. So you're going to see, honestly, a wide range of guidelines being applied across the surgery centers wherever you go, simply because of the variability in the equipment and the experience of the staff that they have there.
Okay, so then let's go through the guidelines. What are the guidelines?
So the guidelines are, again, just to ensure patient safety and ensure that we can do the surgery at the surgery center, are pretty broad. The first one is having a BMI that's less than 45. And if you're about 5 feet and 1 inches, that means a weight of about 270 pounds. And just as a reference. And so the reason we have that BMI guideline is because at BMIs greater than 45, we know that the risk for peri-op complications increases. So it may become more difficult to have an IV placed, within a timely manner. Maybe more difficult to have blood pressure cuffs that fit. Maybe more difficult to measure blood pressure in the operating room. In the operating room, there may be equipment considerations that we just don't have because we have limitations on how much storage space we have for special equipment. In the post-op area, we would have a higher risk for things like post-operative apnea where the patient isn't breathing well, or a finer line between having the patient be overly sedated for pain medications versus not being able to breathe well. We don't have the luxury of having respiratory therapy to initiate things like pulmonary toilet or helping the patient improve their breathing post-operatively.
You can't say pulmonary toilet. Nobody knows what that means.
Well, we don't we don't have respiratory therapy to help with the patient's coughing and deep breathing and helping them clear their And that can be complicated, especially if they've had abdominal surgery. Like they themselves may not be able to breathe deeply because of pain.
Yeah.
So with all those factors to consider, it's what we found that it's safer to not do those patients who have a BMI that's over 45, not in terms of whether they'll survive the surgery, but whether or not they'd be successful in being discharged home and then be safe at home.
Yeah.
One of the biggest
things that I always say to patients is, we don't have plan B, right? We have plan A, and we have to be really sure that plan A is going to work well. And if we think we might need plan B, then we should be doing it in the hospital, right? And so, BMI definitely leads us there. And then, there are other medical conditions, right, where it's just not as safe.
Yeah, so I would say BMI is the most common one. And I would say we don't have a plan B, but our plan B is to stabilize the patient and get them to the hospital.
Right.
And oftentimes with these patients who have a higher BMI, they may seem like they're totally, reasonable to go home, but that at home they're going to be essentially unmonitored and very high risk for not breathing, especially after they take some pain medications at night.
Yeah.
And that's a major risk. We don't want to have someone have a bad outcome at home because they were oversedated.
Well, and I think one of the other things that we think about, and this is much softer, is who's going to be with you when you go home, right? So if you're someone who's a little bit older, you're going to be by yourself when you get home, then, doing a surgery, depending on what it is in the surgery center, just may not be a really reasonable choice because nobody's watching you.
Yeah. And that's actually our second criteria. is that somebody, and this is a national standard, that somebody has to be, so you have to be discharged as a patient, you have to be discharged to the care of a responsible adult. And that doesn't mean an Uber driver, it doesn't mean a taxi driver or the bus driver. It means an adult who's stating that they are able and willing and are going to stay with you for at least the immediate post-op period when you're at home.
Yeah. Are there any other guidelines?
So those are the big ones. Those are the ones that we find are the strictest cutoffs, and we really don't have any wiggle room for those.
Yeah.
Other things that everything else in terms of pre-existing medical problems that the patients may have, we essentially have to, the surgeons and their offices get an algorithm that says, hey, if these patients have these problems, these comorbidities, then that patient should be flagged and sent to me for review. And we also ask the patients, hey, do you have any of these high-risk medical conditions?
Yeah. And I would also say that, sometimes if someone doesn't meet the guidelines, right? But I, for whatever reason, think that it's an okay choice, and I've talked to the patient and they think it's an okay choice, then I'll call you and we'll kind of talk about it and say, hey, I have this patient, here's their story, this is what I want to do. I think it's okay, but let's kind of go over this and troubleshoot a little bit and make sure that, we think it's a reasonable thing to do, right? So everybody's
exactly. So we'll look at things like, someone has a history of, say, heart attacks in the past, and they've had stents or they've had some angioplasty or things like that. That heart may not be as necessarily as healthy as someone who's never had a heart attack. I would go through and take a look at their cardiac records, see when was their last visit with the cardiologist, see if they ever had like an echocardiogram to have actually using ultrasound evaluate the structures of the heart, and see if their heart is working well enough even after the heart attack and the stents or whatever they've had. And so, this person's at pretty low risk, and this would be entirely safe to do at the surgery center. I don't expect there to be any complications.
Yeah.
Knowing that, everyone can have complications, we're also prepared for that. But this person is relatively safe.
Yeah. There's a lot of collaboration that goes on. And, I do a fair number of hysterectomies in the surgery center. And, sometimes people have nausea and pain after hysterectomies. And so one of the things that I'm always doing too is making sure that the patient feels like it's a reasonable option, right? Because if someone is nervous about going home, or if someone wants 23 hours of nursing care, they're going to do better if they get that, right? And you have to go into the procedure believing that this is a good plan for you. Otherwise, it doesn't work as well, right? Things go off the rails pretty quickly.
Absolutely. I think all of this, everything that we do in life requires trust, especially if you're working in a team. And the patients are the core member of that team, especially in a patient care situation. So like I said earlier, we have anesthesiologists who have worked with our surgeons for years. Our least experienced anesthesiologist has been in practice for 11 years. That's me. I'm
going to start calling you that, the least experienced.
The least experienced
there.
I think Dr. Bassett already does.
Not in front of patients, though, right? Since that may not be reassuring.
May not be. But we have a very solid relationship and trust within our team. And the surgeons, they are the ones who select the patients. They're the ones who offer this to their patients as the surgery center as an option. We as anesthesiologists have just a few minutes to build that trust. So we do rely on our relationship with our surgeons, but we also rely on the system that we've put in place to appropriately screen patients.
Yeah.
And that's the pretty robust system. Like, I'm pretty proud of what we've built there, because it's allowed a lot of patients to come through who on face value may not have seemed appropriate for the surgery center. And they've done very, very well. So we've been able to provide that service to the community. But at the same time, we've also been successful in filtering out patients who would be much better served at a hospital with more resources.
Yeah, it does work really well. I think it's great for patients. The collaboration is great for surgeons and anesthesiologists too, right? It's nice to have that smaller, close-knit team, right? I think it works really well. You started talking earlier about the patient experience. Do you want to speak about the patient experience. I get an amazing amount of feedback about the surgery center. What a great experience it was for patients.
Yeah. So I guess I'll start by saying the surgery center was opened right before COVID, like 3 days before the COVID shutdowns happened in March of 2020. And since that time, we've grown from doing a few cases a month to doing about 400 cases a month, and using one OR occasionally to using all 5 of our ORs almost all the time. So there's been a lot of growth in the last 3 years. And so what patients experienced 3 years ago may seem slightly different from what they experienced, say, this week, just in terms of the busyness and stuff. But the one thing that we've done very well is throughout all those changes is to work to maintain a very positive culture. And for us, culture is one of the most powerful yet almost immeasurable or invaluable elements of the East Pavilion Surgery Center. We have a very dynamic team of leadership. Jess Hawkins and Rachel McCarthy work very well together. It's often you'll see them in each other's offices talking and troubleshooting and working on problems together. They make themselves very available to the team to help with last minute questions or provide resources as needed. The core group of anesthesiologists, so we're pretty lucky that we have a full roster of anesthesiologists with 7 people who have the East Pavilion as their primary work site. And so that allows us to provide a very consistent product, not just in terms of patient care, but in terms of developing and following policies, understanding changes when they need to be made, and then working with each other and collaborating with the team to ensure that patients always have at least one anesthesiologist who's readily available if the nurse or the surgeon have any other questions. We have, just speaking very quickly in terms of the culture, we have monthly, if not more frequent celebrations to, highlight the work that our team's done. During the growth phase, it's easy to either get bogged down in the details and feel like you're just suffering through growing pains, or it's easy to over celebrate every small achievement as a major milestone. And I think the growth that we've had and the success we've had in keeping patients safe, keeping our staff and our surgeons happy, and providing this during some pretty chaotic times is a milestone and achievement that speaks for itself and can't really be celebrated, but it should. So, this year the East Pavilion Surgery Center received the Center of Excellence Award for the State Society for Ambulatory Surgery. And it's one of those places where you work, you can feel that the vibe is very positive. We have a great backroom culture where people get together and share meals, share breaks. There's a lot of egalitarianism within the staff and among the physicians and the staff. And it just helps to create a sense of shared commitment and shared values where, again, patient safety is first. We're there to work, but we also really just enjoy being in each other's company.
And I think
I don't know if you can...
patients can feel, right? I mean, when people enjoy working in a place, when we're all working together, I think that is palpable to the people that come through the door and makes it a more pleasant experience.
I agree. And I think one of the biggest factors we have is that we are a relatively small center, especially when compared to like a major hospital. So there is a greater degree of accountability, not just in the quality of work that you're doing, but in the mood that you're bringing to the surgical center. So, if you're in a grumpy mood, you're going to affect a lot more people proportionately than you would if you were in a grumpy mood at a hospital. And so people will talk with you and try to cheer you up. And I think people just recognize that they're working with a very close-knit group of colleagues.
Yeah. And it's not to put the hospital down, right? I think the hospital does a very good job as well. But I think maintaining that positive culture and being very aware of the patient experience and how nervous people are before surgeries and really easing that is an important focus in our surgery center. And, the patients definitely benefit from that. Whereas, in the hospital, the focus may be more on the work rather than the environment and the experience.
Yeah. I think part of it too is, the hospital is doing some pretty heavy lifting, especially in the COVID era with the types of cases and the work that they have to do. And I'm not saying that we're, sitting there and just having a blast and, shooting off firecrackers at the end of each case, nor are we cherry picking the easiest cases. But we have a different focus. We know our day ends at 5 p.m. ish, whereas the hospital just has to keep going. And there's always more work there.
Yeah.
There's more to do.
So We focus on patient experience. We focus on patient safety. When does the patient interface with the anesthesiologist at the surgery center? Do you always call patients
So,
the night before? How do you guys do that?
yeah, our goal is to always call our patients the night before. That's our stated goal. Our metric that we use to measure how successful we are is to ensure that patients were contacted at least 75% of the time. And the reason we do that is that, sometimes the assignments change very late into the evening, and it may not be possible to call the patients at a reasonable hour. Sometimes the anesthesiologist is busy and stuck in a situation where they may not be able to call. So we also have to do our own administration, our own quality assessment, quality improvement. And a lot of this work is done, obviously not in the operating room. So, there's only so many hours in a day. And if you're spending the hours immediately after work taking care of paperwork or administrative work, it may be 8 p.m. before you're free enough to call your patients. And at some point, you probably want to go home and have dinner and see your family if that's what you have. So sometimes it just gets too late in the day. So, that would be like the earliest you would see the anesthesiologist or talk with the anesthesiologist. And that's because the assignments are made the day before and finalized the day before. The second time you would see the anesthesiologist is in the pre-op area, after the nurse has brought you into the pre-op area and had you change into a gown and put in an IV and done their pre-op intake. And then you generally have a very quick pre-op interview. The anesthesiologist has already looked over your records, which are whatever is available through electronic medical records. They've looked over any notes that I may have written in terms of your risk assessment, especially if you've got a pre-existing condition that's been flagged as being higher risk, and my assessment of where you are with that condition. And then they'll talk with you. They'll do a quick physical exam, go over the anesthesia plan with you, get your consent, and then the nurse will bring you back to the operating room when they're ready in terms of the paperwork and the equipment and the setup for the room.
Yeah. What do you do to put patients at ease?
Well, I've got my trusty handbook of great jokes, a couple of references to pirate jokes, so that's always great.
Did you always do that? Did you always tell jokes, or is that something you developed over time?
I always told jokes, although the first 2 jokes I told I got into a lot of trouble for. So I can't say them because they were...
Because they were inappropriate, or because...
Well, because the patient laughed too hard, and then they were like not, they just got like goofy. And they're like, all right, you can't make them laugh too hard. So now I told groaners instead of knee slappers.
That's hilarious. I just thought you liked bad jokes. I didn't realize that you trying to hit the laugh metric very precisely.
Yeah, you don't want to get yanked off the Apollo stage, right? But you want the Sandman to sort of be ready for you.
Yeah, I can confirm that you tell groaners.
Would you like to hear my latest one?
Most people at ease.
Would you like to hear my latest one? I just thought of it like yesterday. I
hesitate to say yes, but since I know I will hear it at some point, yes, please go ahead.
So good. What did the vegan zombie eat?
So the minute you say "so good," I know I'm in trouble. I have never heard you say your joke was so good and have it actually be okay.
Come on, quickly.
What did the vegan or vegetarian?
Vegan.
Okay, what did the vegan zombie eat? That was your joke?
That's the question, yeah.
Okay.
Grain.
What?
Grains.
I have no words. I can tell you that would not make me laugh too hilariously for anesthesia. So
exactly. That's too much. Yeah, so that's basically what we do. We have a very, very short window in which to reassure the patients. And some patients are like, hey, I'm an old hat at this. I've had surgery multiple times. I know it's a quick procedure. I'm not worried. And some people are like, I've never had surgery before. I hate needles. I hate being in clinics and medical offices. Get me out of here.
Yeah. I think the norm is that people are nervous, though.
Right? Yeah. And I think that's normal, right?
Yeah.
They're not having surgery every day, I hope.
Right. And it's kind of a foreign place, right? I mean, nothing about it feels familiar or comfortable for most people.
Right. And I mean, ultimately, you're giving up control of your body
Yep.
for at least a relatively brief period. And that can be very intimidating for anyone.
Mhm.
So, we do what we can. So there's common things like just talking with the patient, reassuring them of the plan. Some people get a lot of confidence and comfort knowing that the plan has been explained to them pretty thoroughly. Some people, that's not enough, but they need more like physical comfort measures, like a warm blanket or privacy or having the TV or a family member in the room. So obviously, all of that stuff is easily available. Some people need medications, so if Xanax or a Valium is going to help, then we have that available. And we try to give that before the IV goes in because that can be the first anxiety causing trigger. Some people, even with all of those measures, still feel like, hey, this is just how it is. I'm an anxious person, and nothing that you're doing is helping. I appreciate it, but it's just not helping. So when we go back to the operating room, we tell a few jokes. We can try to reassure them that things will be okay. Try to let them have as much control of their body as possible, and give them clear direction so they know what to expect. Set up those expectations. And then we also have just IV medications that we can give to help with anxiety. You would give those at the very end of the pre-op experience before they go to sleep so that if they have anything they want to say, they can remember, they can tell us, because those medications can alter your memory and make it difficult to know, just how with it you are. Afterwards in the recovery room, it's the same, pretty much the exact same measures. So we can just do some coaching. We can do some physical measures. We can do some medications and reassurance and go from there.
Yeah. In the post-op area, well, in the pre-op too, I mean, these rules have changed over COVID. Family members can come back. And I think sometimes having, a family member or a partner back is super helpful.
Yes, absolutely. And it's totally normal. Like I said, people don't have surgery every day.
No.
You always tell them, if I'm nervous, then that's one thing. But if you're nervous, that's totally fine.
Yeah. I mean, I had a very reasonably anxious patient recently. And the thing that was most helpful for her was to have her husband back almost immediately. Right? So she saw him right as she was waking up. And, we were able to do that. Right. So I think, personalizing it and being aware of the patient and their needs is important. Although, not everyone knows how they're going to react after anesthesia.
Right. Right.
So, yeah. All right. Is there anything else that you want to mention about the surgery center?
Other than it's a great place to work. It's definitely been the highlight of, well, I can't say that because I just got married. It's been one of the highlights. It's been one of the highlights of the past few years, even during the dark times of COVID. I think that people will in the future, people being just the general population, but also the medical profession, will look at surgery centers as a safe, efficient, low-cost alternative to hospitals. And I think we've already seen a lot of growth, not just at the East Pavilion Surgery Center, but just surgery centers nationwide. The amount of savings that we achieve by focusing just on surgical services is significant. I mean, we're talking on the order of maybe couple $1,000 for patients, depending on the procedure.
Right. And I think that's an important thing that, patients don't always realize is you can have the same surgery in a surgery center or a hospital. And generally it is cheaper for the individual at a surgery center. It'll charge more because they have more costs and,
more overhead,
more facilities.
Yeah. I think it's not necessarily a downsizing of hospitals, but it's the proper utilization of resources. I mean, we have essentially everything that we would need to do a safe surgery. Otherwise, we're not doing the surgery there.
Oh, right.
And that's huge.
Yeah. Yeah. And that, I think when you look at it as being an option that is cheaper, more efficient, focusing on the patient experience and safe, if it is a surgery that qualifies for a surgery center, then it's a great option, right? There are a lot of ways that it is better for patients.
Well, I honestly think in the future, it's not going to be considered, and by future, I mean like in the next few months to maybe the next year or two, it's not going to be considered as an option, but as the primary option.
Yeah. I mean, there are definitely some insurance companies that are already doing that, right? That are saying this type of procedure has to be done in a surgery center because it's just for all of those reasons, right? It is as safe, it is more efficient and cost effective for everyone.
The surgeons too, like there's many practices that are surgical specialties that are moving almost exclusively to surgery centers.
Yeah. I mean, there are, I've definitely moved a lot of my practice there. I've worked in a surgery center for a long time now, mostly because it was cheaper for patients for smaller surgeries. But, over COVID, we learned that patients didn't have to spend as much time in the hospital and patients didn't spend as much time in the hospital. And so, that has led me to do more and more surgeries as an outpatient because it was just kind of a natural experiment that happened. And patients did great and liked it better. So it made a lot more sense, right? It was really driven by patients wanting to go home, not lack of resources. So,
and just to go full circle, that's how you started out, saying that so much of this centers on the patient's expectations.
Oh yeah.
So if the patient is, wanting this, it is something that we offer every day.
Yeah.
But we have to have buy-in.
They have to be totally on board. I know when I have a patient who hesitates, I know it's not a great option. So, and, even recently I've, in the preoperative appointment, right, where we know where we're doing the surgery, it is one of the things that I go over, right? We're doing this in a surgery. You're going home the same day, right? You still feel like this is a good idea because if it's not, then they should change. So, yeah.
Exactly.
Well, thank you so much for your time. Thanks for all. As you know, I always like working with you, groaner jokes and all. I'm glad.
Great.
Okay, so on that note, I'm going to let you go. And thanks again.
Of course. Good to see you as always.
Thanks for listening. If you want more information about me or my online work, check out my website at www.thewomensbladderdoctor.com.